Hello, welcome to this third and final video on imaging, anatomy, and pathology of the neck spaces. We've covered most of the neck spaces in the previous videos. I'm now going to pick up where I left off in video number 2, and I'm going to talk about anatomy and pathology of the retropharyngeal space. The retropharyngeal space is a virtual space. You can't actually see it when it is normal, but when there's pathology present over there, it can be very severe. First, let's define the retropharyngeal space. Where is it located exactly? So this here is the pharyngeal mucosal space and visceral space. We know those spaces already. And these are lined by the middle layer of the deep cervical fascia. Then at the back, we have the perivertebral space. Actually, it is more extensive than this, but I only drew the prevertebral compartment of the perivertebral space, and it is lined anteriorly by the prevertebral fascia. Now, located between the middle layer of the deep cervical fascia and the prevertebral fascia, which is part of the deep layer of the deep cervical fascia, we find the retropharyngeal space. As said, it is a virtual space, and despite the fact that it is very, very small when it is normal, it is even further divided into two spaces by the alar fascia. The alar fascia is a component of the deep layer of the deep cervical fascia, located anteriorly of the prevertebral fascia, and it divides the retropharyngeal space into two components. Anteriorly, we have what I will call the true retropharyngeal space, and this space basically ends at somewhere between the first and the sixth thoracic level. So I said here, let's say at the third thoracic level. And then posteriorly, we have what is called the danger space. And why the danger space? Because this space extends all the way to the mediastinum. So if you have a disease process involving the danger space, this disease process can extend all the way to the mediastinum. So when it's an infectious process, it can cause mediastinitis. Okay, so this is the anatomy of the retropharyngeal space. As said, it is so thin that in normal situations you can't really see it. So I tried to draw it over here, but it is so small that I can't accurately draw it on this axial T2 weighted image. So this is an approximation. In blue, you see the visceral fascia or the middle layer of the deep cervical fascia. And then in red, we have the prevertebral fascia of the deep layer of the deep cervical fascia. And the retropharyngeal space extends all the way from the suprahyoid to the infrahyoid neck. And when it comes to the danger space, this extends even further all the way into the mediastinum. Then the retropharyngeal space is further divided in two spaces by the alar fascia, as explained previously, with the anterior part being the true retropharyngeal space and the posterior part the danger space. In normal situations, it is extremely thin. It's a virtual space containing mainly fat. So here we see the two components. Well, I just drew one space in green over here, but what can we find in the retropharyngeal space? Well, mainly fat, some lymph nodes, and as said, the true retropharyngeal space stops at about the third thoracic level. The danger space contains only fat, but it extends all the way into the mediastinum. This is an axial T2 weighted image. This was a young boy who received an MRI of the brain, and as an incidental finding, we saw these lymph nodes in the retropharyngeal space. You have two lymph node groups in the retropharyngeal space. You have a medial group and a lateral group. Lateral lymph nodes are often an incidental finding, especially in children. They are not necessarily a sign of pathology, like in this child there was no head and neck disease present, so we didn't give these lymph nodes too much attention. And in this patient, we see a fat-containing lesion located in the left part of the retropharyngeal compartment. Notice You see here this muscle over here, this prevertebral muscle. This is the longus colli muscle, and it is a bit displaced posteriorly, proving that this lesion originates in the retropharyngeal space. It's fat containing, it's a lipoma. So in these two patients, we see what we can find in a normal retropharyngeal space, namely fat and lymph nodes. Now, what kind of disease entities can we encounter in the retropharyngeal space? Well, basically, we can see three things. We can see enlarged pathological lymph nodes, so lymphadenitis and inflammation of lymph nodes, often secondary to a disease process elsewhere in the head and neck, for instance, a tonsillitis with secondary lymph node involvement in the retropharyngeal space. We can have a retropharyngeal abscess, and we can have retropharyngeal edema. And those two are not the same, and the distinction is quite important, as you will see. Let's look at this swallowing investigation performed in a 70-year-old male patient following surgery for a Zenker diverticulum. The patient was a bit feverish, had dysphagia, and a swallowing study was performed to see if he had a perforation somewhere, some leakage of contrast. We couldn't see anything, but one thing is conspicuous. Take a close look at the prevertebral soft tissues. These are quite thick, way too thick. They shouldn't be this thick normally. On this X-ray of the neck, we can also see how swollen and enlarged the prevertebral soft tissues look, and also notice the presence of an air fluid level over there. Of course, with this finding, we did a CT of the neck, and what do we see? We see a retropharyngeal fluid collection containing air bubbles. This was a retropharyngeal abscess, a complication of the surgery the patient had undergone a couple of days earlier. And why do we call it an abscess? Well, let's look at the axial images performed at about this level, and we see a fluid collection in the retropharyngeal space with an enhancing capsule. And that's very important. When we see fluid with an enhancing capsule, we call it an abscess, and this is something that needs to be drained. When seeing a retropharyngeal abscess, it is very important to look at how extensive the abscess really is. Is it limited to the neck, or does it extend all the way down into the mediastinum? Let's take a look at another patient with a retropharyngeal abscess. Here we see a fluid collection with air bubbles in the retropharyngeal space. Now, is this located in the true retropharyngeal space or in the danger space? We can't say. You can't see the alar fascia, so you're never sure where it is located exactly. So that's why it is important to look at your sagittal images to look how extensive the abscess or the collection truly is. And in this patient, we saw it extending all the way down into the chest, all the way further down up until the upper abdomen. So this proves that this retropharyngeal collection was located in the danger space and caused a secondary mediastinitis. On these axial CT images with iodine contrast, we see the collection extending all the way into the mediastinum. We see a large collection involving several lymph node regions or several regions of the mediastinum, and it extends even further down along the thoracic aorta, further into the abdominal cavity. So this was quite extensive, and this patient was very severely ill. Retropharyngeal abscesses are potentially life-threatening infections in the retropharyngeal space, especially when they involve the danger space, because we cannot see if the danger space is involved directly or not. It's very important to evaluate the extension of a retropharyngeal abscess and to make sure it is limited to the neck and to exclude extension into the mediastinum. Now, the patients I've shown you were adult patients, but retropharyngeal abscesses are actually most frequently encountered in children, especially young children, with about 3/4 seen in children ages 5 and less. And why are children so vulnerable to the development of a retropharyngeal abscess? Well, because they have abundant retropharyngeal nodal tissue and frequent middle ear and nasopharyngeal infections. Retropharyngeal abscesses are often secondary to an infection somewhere else in the head and neck. Because if you have an infection somewhere in the head and neck regions, secondarily, retropharyngeal lymph nodes can become involved as well. They can suppurate and they can break through into the retropharyngeal spaces, causing an abscess there. Here we see two children with a suppurative retropharyngeal lymphadenitis. We see enlarged lymph nodes that are centrally hypodense due to the presence of pus. And when these lymph nodes rupture into the retropharyngeal space, the infection spreads into the retropharyngeal compartment and can cause a retropharyngeal abscess. Here we see a child who received an MRI of the neck. The child also had a head and neck infection. I believe it was a tonsillitis, but I'm not sure anymore. The most important thing is we see these enlarged lymph nodes, and okay, every now and then you see somewhat larger lymph nodes in the retropharyngeal space in a child, but this lymph node clearly had some central necrosis or some central suppuration. So these lymph nodes, especially the right one, cannot be considered normal. A week later, the child received another MRI of the neck, and we see that one of the suppurative lymph nodes has broken through into the retropharyngeal space and caused a retropharyngeal abscess. This is a nice illustration, but it was not nice for the child, so I should use another way of describing it. This is a very educational illustration of how we develop or how you can develop a retropharyngeal abscess. Let's summarize. They are generally caused by a head and neck infection somewhere, can be sinusitis, can be a middle ear infection, can be a tonsillitis or a peritonsillar abscess, causing secondary spread to the retropharyngeal lymph nodes, which can evolve into a suppurative retropharyngeal lymphadenitis, and that can rupture into the retropharyngeal space, causing a retropharyngeal abscess. Scrutinize the extension of the abscess, exclude mediastinal involvement, because that's possible if the infection is located in the danger space instead of the true retropharyngeal space. This is another patient who clearly had some fluid in the retropharyngeal space, but if we look at an axial CT image, we see no enhancing capsule. This is the fluid accumulation in the retropharyngeal space located between the prevertebral soft tissues. These are the muscle bellies of the longus colli muscles, and here we see the hypopharyngeal region. So there is no enhancing capsule, so this is not an abscess. This is retropharyngeal edema, and retropharyngeal edema is almost always secondary to a process somewhere else in the head and neck region, so look for it. In this patient, well, the question is why? We saw some cloud-like calcifications involving the left longus colli muscle, located anteriorly of the dens, and this is the typical imaging appearance of calcific tendinitis of the longus colli muscle. This is basically these calcifications are caused by hydroxyapatite crystal deposition, and this can invoke a very severe inflammatory reaction. These patients present with neck pain, and due to the proximity of the retropharyngeal space, we can see a retropharyngeal edema in these patients, as was the case in this patient. Here we see two other examples, both are children. This child clearly has suppurative lymphadenitis in the posterior cervical space and secondary some reactive retropharyngeal edema. It's not an abscess because we do not see an enhancing capsule. In this child, we see a bilateral tonsillitis and also some secondary retropharyngeal edema. The main clue of this finding is if there is no enhancing capsule, it's not an abscess, and look for the cause of the retropharyngeal edema. The distinction between retropharyngeal edema And a retropharyngeal abscess is very important because a retropharyngeal abscess will need to be drained. Retropharyngeal edema can be left the way it is. The goal here is to treat the cause of the edema. Let's move on to the next space, the perivertebral space. The perivertebral space is enclosed by the deep layer of the deep cervical fascia, and in this space we find centrally the vertebrae, both the bodies and the posterior elements of the vertebrae. These are surrounded by muscles. Those located in front of the vertebrae are the prevertebral muscles. We also have the scalene muscles and the paraspinal muscles in this compartment. These are the main components of this space. This space also contains several neural elements, such as the brachial plexus and the phrenic nerve, and some vascular structures like the vertebral artery, seen over here, and the vertebral vein. When it comes to pathology of the perivertebral space, I'm going to show you the three most important ones and probably the most frequent ones. We have infectious disease, spondylodiscitis, so an infection originating in the vertebral bodies or the vertebral discs, depending on which can extend into the surrounding perivertebral muscles and the perivertebral compartment. We have tumorous disease, most frequent, especially in the older population, would be bony metastases, which can have soft tissue extension. So when you have a bony metastases and the cervical spine, these metastases can be associated with a tumorous soft tissue component that can extend both in the perivertebral soft tissues as well as in the epidural compartment intraspinally. And finally, a final example of a tumor you can encounter in the perivertebral compartment would be a schwannoma. They typically originate somewhere in the neuroforamen and can extend into the perivertebral compartment. Let's show you some examples in a bit more detail. This was a young boy in whom we discovered a perivertebral collection that looked quite inhomogeneous and irregular on an MRI of the neck performed for neck pain. And the patient was having neck pain for several weeks at that moment. So we see a very large perivertebral component, but also an intraspinal component. The perivertebral space communicates with the epidural space inside the spinal canal. So it's important to keep that in mind. If you have a disease process in the perivertebral space that can extend in the epidural space of the spinal canal. On bony reconstructions, we saw an area of lytic destruction of part of the atlantodental joint on the right side, and the final diagnosis in this patient was tuberculous spondylodiscitis, or tuberculous spondylitis rather, because the disc was not involved. Well, there was no disc at that level. Then these are T2 star images of the same patient. We see a very large T2 hyperintense collection and the perivertebral soft tissues also extending. It's difficult to say if this is in the retropharyngeal compartment or still in the prevertebral soft tissues. I'm assuming the former, but we can't really say for sure, I believe, on this image, with inhomogeneous, especially peripheral enhancement on T1-weighted images with gadolinium. The same patient had a second focus lower in the spine. This is at the level of the lumbar vertebrae. We see here the cauda equina, and we see involvement of the pedicle of one of the lower lumbar vertebrae with a large collection extending into the paraspinal muscles. The perivertebral compartment extends all the way from the skull base to the coccyx, so this is a quite extensive space. It is not limited to the neck. This was a patient with a bacterial spondylodiscitis, so we see very large soft tissue inflammation on this T2 star image surrounding one of the cervical discs. We see infiltration on an enhanced T1 weighted image of the perivertebral spaces, which is irregularly enhancing and also involves the epidural compartment in the spinal canal. So this is an example of a bacterial spondylodiscitis. This was a patient with bony metastases. Look at the diffusely inhomogeneous signal on T1 weighted images due to the presence of metastatic infiltration of the vertebral bodies and also the posterior vertebral elements. And on T1 weighted images with FATSAT and gadolinium, we saw at one of the lower cervical levels a very large soft tissue component involving the right paraspinal muscles and also the epidural space surrounding the spinal canal. A final illustration, and here we have the paraspinal component and here the epidural component. A final illustration of the disease process in the perivertebral compartment would be a schwannoma. We've already seen schwannomas when talking about carotid space tumors, so they are benign, slow-growing tumors. In the cervical spine, they often originate in the neuroforamina, where the nerve roots exit the spinal canal, and these tumors can extend through the neuroforamen into the perivertebral space, which this tumor is also doing to a limited extent. Because they are slow growing and benign, they often cause enlargement of the involved neuroforamen and some benign scalloping of the surrounding bony structures. This tumor here was homogeneously enhancing, but especially large schwannomas can become centrally kystic and can have areas of central necrosis. So this is another schwannoma. Notice the enlargement of the neuroforamen and the extension into the perivertebral compartment or the perivertebral space in this patient. So to summarize, the main pathological entities we can encounter in the perivertebral space would be spondylodiscitis, bony metastases with soft tissue components, and schwannomas. Now we're almost through. The last couple of spaces I'm going to talk about are actually quite small and limited in the types of pathology you can encounter there. And the supra and infrahyoid neck, we find the posterior cervical space located behind the carotid space between the layers of the middle and the deep layers of the deep cervical fascia, and this space contains mainly fat, lymph nodes, and neural elements. If you know the components of a particular space, you can already kind of predict what you will find here. Fat, well, lipoma is always a possibility, but you find fat in practically every space. The lymph nodes, so enlarged lymph nodes, neural elements, so theoretically a schwannoma would be possible, but you don't often encounter them there, of course. Here we see a patient who had a head and neck tumor, can't remember where, with enlarged pathological lymph nodes, this one with central necrosis in the posterior cervical space, and here we have a lateral retropharyngeal central necrotic lymph node. In this patient, we see a large venolymphatic malformation in the posterior cervical space. This case was taken from a publication by Dr. Stephanie van den Bosse. I will provide a reference at the end of this presentation. So these are two types of pathologies you can encounter there. In the anterior cervical space, well, we only have fat, so basically pathology in this space is mostly extension from pathological entities in the surrounding spaces. So it's just a very small fat-containing space in the infrahyoid compartment. Okay, that concludes my 3 presentations on anatomy and pathology of the neck spaces. My key messages are going to be brief. I hope that at the end of this presentation, neck spaces are no longer a source of torture for you. Neck spaces and neck anatomy can be difficult, but I hope this step-by-step approach made it clear, and a good knowledge of neck space anatomy is essential. The localization of a disease entity in a particular neck space will determine your diagnosis or differential diagnosis. We have seen 4 spaces that cross the entire length of the neck: the carotid space containing vascular structures and cranial nerves. So it is the seat for potentially schwannomas and glomus tumors. We have seen the retropharyngeal space, and the most important entities there are retropharyngeal edema, which is secondary to an infection somewhere else or a source of inflammation somewhere else, a retropharyngeal abscess, and then it's very important to exclude extension into the mediastinum, and we've also seen suppurative lymphadenitis. And the perivertebral space, the main sources of pathology are tumors or infections, but that is basically true for every neck space. When it comes to infections, I'm talking about spondylodiscitis. When it comes to tumors, you can have bony metastases or schwannomas, and the posterior cervical space, which contains mainly fat and lymph nodes. So if you see something over there, it's mostly going to be lymph nodes. And the suprahyoid neck, the parapharyngeal space, is basically the center of your neck spaces. It's the crossroad of all the neck spaces. So try to recognize patterns of displacement to locate the space of origin. Okay, that concludes my presentation on imaging, anatomy, and pathology of the neck spaces. I found this an extremely good and interesting article, Upper Neck Spaces, Anatomy and Pathology, by my colleague Dr. Stefanie van den Bosse, published in the Handbook of the European Society of Neuroradiology. It's definitely, I've read a lot of articles on the subject. I found this one extremely good because it's very, very practical. And at the end of the day, those kind of articles are for day-to-day clinical radiologists, the best ones, because we can use the information immediately in daily clinical practice. So if you want to read up on this subject, I would advise you to check out this article. Well, it's a book chapter, but check it out because it's very good. Thank you for watching. This concludes my presentations on imaging, anatomy, and pathology of the neck spaces. If you have any questions, comments, or feedback, leave a question, comment, or some feedback in the comment section, or you can also send me an email, neuroradiology.online@gmail.com. I try to reply to everyone. It might take me a while, so I don't reply immediately. I do like once a week or so. I try to reply to most emails I've got, so I don't always get there. So don't be offended if you don't receive a reply immediately, but you'll definitely get one sooner or later. So thank you for watching, and I'll see you for a future presentation, I guess. Bye. How do I close this?